MECSF as a diagnosis is really broad. People can come in with initially having a secondary diagnosis or even a primary diagnosis with a secondary, chronic fatigue component to their case. And I think that doing our due diligence and looking at the hormonal aspect of what chronic fatigue can encompass, is there an adrenal deficiency? Is there a thyroid deficiency? We may fall into normal, what we would call euthyroid on lab, where everything looks right, and yet working on those hormonal aspects to the case can really make a huge difference in their overall chronic fatigue. And if I can get their energy better, they're going to be much more willing and capable of doing what it is that we're asking them to do in regards to treatment as well. So I definitely do put I don't just put everybody into this category of MECSF, because we can have chronic fatigue that has nothing to do with mast cells. And mast cells can be a major player in the chronic fatigue cases that we have as well. So making sure that we've got all of our arsenal of things that we can do for mast cell activation syndrome, and as well as all of the other intricate components, I believe, of the endocrine system to be able to support them, I think becomes my focus and the direction that I want to go, in adjunct to possibly treating infection at the same time. Where I think that bleeds into the potential of some sort of autoimmune component to a case. A lot of MECSF cases have this sort of neurological, cognitive deficit as well. And being able to piece apart the components that might also be some sort of post-infection autoimmune encephalitis, or, we could generalize that as brain inflammation, but doing everything that we can to get a more specified diagnosis. Sometimes that looks like looking at a Cunningham panel, possibly, looking at more autoimmune neurological antibodies to be able to possibly qualify this person for immune globulin therapy, IV immune globulin therapy, or sub-Q immune globulin therapy. And there's been more expansion in this realm of recent in getting patients qualified for immune globulin therapy, utilizing Cunningham panel or tests that are similar to this. I think where I find that to be extremely helpful is when I've got a patient that is post-infection, does still have this brain neuro component to their case, that also is still really struggling to maintain the benefits of therapy. It's never going to be my goal to treat somebody for any longer than they need to be, especially with an antibiotic therapy. And so when I find those patients do very, very well on therapy, but then they start to decline and have deficit, or they continue to rebound over and over again, and so there could be an immune deficiency that might qualify them for IVIG as well. But they also are having a lot of these neurocognitive deficit, then, looking at immune globulin therapy as a potential direction to go as well.